Yes. Are you able to hear me? All right. In the last class, we have seen about the foregut. So today we'll be seeing the development of the midgut and the hindgut. Okay. All right. So before we go into this, I will just show you some of the videos. Okay, some videos on which is already there in your Langmans. Okay, which is already there in your Langman. So which is a continuation. When you get a Langman book, you will get this CD. Okay, the animation video. So this was what we have seen previously, the amniotic and the yolk sac. Okay, the oropharyngeal membrane and the cloacal membrane, then the cephalocaudal folding, okay, transforming into a foregut, midgut, and hindgut. The midgut is getting connected to the yolk sac. Gradually, it gets narrowed down, okay, forming the vitellointestinal duct. Okay, the vitellointestinal duct. Okay, in the foregut, the respiratory diverticulum, the liver bud appears. Okay, and this is just the same. I think all this we have seen. Let me proceed on directly to the development of the midgut. So that's the development of the pancreas. All right. So how the pancreas becomes a retroperitoneal structure. So we have seen this until the last session. So today we will be seeing about the development of the midgut. Okay. So the development of the midgut. So only this portion. Okay. You know that the midgut is connected. The midgut is connected to the yolk sac through this vitellointestinal duct. Okay. And the midgut is supplied by the superior mesenteric artery. Okay. It is supplied by the superior mesenteric artery. Okay. So now the midgut can actually be divided into two parts. The part before this superior mesenteric artery, the part after the superior mesenteric artery. Okay. So the part before the superior mesenteric artery, the part after the superior mesenteric artery. So the part before, it's called as cranial limb. Okay, cranial limb of the midgut. Okay, and the part after is called as a caudal limb of the midgut. Okay, another name what they give is as pre-ileal, post-ileal. Okay, that I will tell you like why it is being named as pre-ileal and post-ileal. Okay, later. So here this will be the cranial limb and this will be the caudal limb. Okay. Now what happens is initially there is a 90-degree rotation. Okay. So there is 90-degree rotation. So let's see. This is the midgut loop. Okay. It rotates 90-degree clockwise or anti-clockwise. It is rotating 90-degree anti-clockwise. Okay. It is initially rotating through 90-degree anti-clockwise. Okay. Now, when it rotates to 90-degree anti-clockwise, what happens to the cranial limb? The cranial limb, the convolutions increase. Okay, that is the length of the cranial limb of the midgut increases. Okay, it increases at a drastic rate rather than the caudal limb. Okay, the cranial limb increases in length, so there will be a lot of convolutions in the cranial limb. Okay, then what happens? Okay, then a further 180-degree rotation. Okay, then there is a further 90-degree rotation and another 90 degrees. So totally 180-degree rotation. All right, and what happens during this time? The convolutions in the cranial part increases. Okay, and there is a small bulge. Okay, there is a small bulge which is located in the caudal limb. Okay, in the caudal limb. This is called as the cecal bud. Okay, this is called as the cecal bud. Okay, cecal bud. Okay, now further 90 degrees, so totally 180 degrees. Okay, so 90, then 90, another 90. Okay, so totally 270 degrees. Okay, so 90 plus 90 plus 90. So 270 degrees rotation, anti-clockwise direction. Okay, so now what happens? The next part, just observe this closely. Okay, the last 90 degrees. In the last 90-degree rotation, can you see both the cranial limb as well as the caudal limb? They are going inside the body. So initially you can see. So initially you can see that the midgut is protruding through the umbilicus, but Dr. Chan, I'm in class. Okay, so here you can see the cranial limb and the caudal limb. The cranial limb is taken inside and then the caudal limb follows it. Okay, so initially if you see both the midgut and the hindgut, they are protruding through the umbilicus. Okay, they are protruding through the umbilicus. Okay, then what happens after this rotation? Okay, during this rotation, the cranial limb, the size increases, the length of the cranial limb increases, and there is a bud which develops, which is called as the cecal bud. Okay, then the last 90 degrees, the cranial limb goes inside first, and then the caudal limb is taken inside. Okay, you can see that now. Yes. So reaching the final position. Okay, so the reaching the final position. I will show you another one YouTube video. So here also. So you know that the midgut is developing from the superior mesenteric artery. Okay, and this is another animation which shows it. The vitellointestinal duct. This is connecting to the yolk sac. Okay, so initially the midgut is elongating along the umbilicus, the developing umbilicus. This part is called as the cranial limb, and this part is called as the caudal limb. Okay, the cranial limb is the one which develops into the distal part of the duodenum, jejunum, and a part of ileum. Okay, whereas the caudal limb is the one which develops into a distal ileum, okay, cecum, appendix, ascending colon, and 2/3 of transverse colon. All right. Now, so first initially 90-degree rotation anti-clockwise. Okay, 90-degree rotation anti-clockwise. So in this time, the cranial limb, the convolutions, they increase. Okay, the cranial limb convolutions, they increase. In the caudal limb, there is the formation of the cecal bud. Okay, there is a formation of the cecal bud. Okay, now what happens during the further to the 180 degree? First 90 degree, then 180 degree. During the further 180 degree rotation, anti-clockwise direction, okay, the both the cranial and the caudal limbs, they are taken in, thereby going on to the adult position. All right. Any doubts? Any doubts? Okay. All right. Now, once again, I'm just repeating it. The rotation. Okay, so the first 90-degree rotation, during which the cranial limb, the foldings increase. Okay, the midgut is initially protruding through the umbilicus. Then during the next 90 degrees, okay, the convolutions increase and there is the formation of cecal bud. Okay, and during the last 90 degrees, the cranial limb goes inside first, okay, and then the caudal limb goes, okay. So that's why in the adult position, okay, so this is the adult position. So in the adult position, you can see the stomach, the duodenum, and in front of the duodenum is the transverse colon, okay. There is transverse colon, all right. And here,
Sir, I have a question.
please, I'll give you time for questions, okay. Okay, so this is the, please write down your questions. I'll give you time. Okay, so this is the stomach, duodenum, jejunum, ileum. Okay, and this is the proximal ileum, and this is the distal ileum, the cecum, appendix, and transverse colon. Okay, two-thirds of the transverse colon they develop from the midgut. Okay, and here you can see in front of the duodenum there is transverse mesocolon, which is in the adult position. In the adult position, whenever you open up the abdomen, you can see that the duodenum is a retroperitoneal structure, and in front of the duodenum there is mesocolon, the transverse colon. Okay, so now you know like why the transverse colon is in front of the duodenum. Okay, so that's because the cranial limb goes inside first, and then the caudal limb is taken inside. Also, another thing you note that the cecal bud. Okay, the cecal bud. The cecal bud initially is in the hepatic right hypochondrial position. Okay, subhepatic region. Okay, so initially the cecal bud is in the subhepatic region. Okay, so that is below the liver. Then later on, what happens? You see, there is descent of the cecum. The cecum then descends down. Okay, so now initially the cecum was there below the liver, then the cecum descends down. All right, so thereby getting into the position, the right iliac fossa region, the cecum. Okay, so this is the rotation. This is regarding the rotation of the midgut. Okay, this is regarding the rotation of the midgut. All right. Okay. Now, once again, I will just tell you the last one. The midgut initially protruding out through the umbilicus. Okay. Then there are foldings during the first 90-degree rotation. There will be increased foldings in the cranial limb. Okay. During the next 90 degrees, there will be the formation of the cecal bud. Okay. The cecal bud. And the last 90 degrees anti-clockwise rotation, the cranial limb goes inside first and then the caudal limb follows. Okay, the caudal limb follows. Okay, finally the cecal bud, which is located in the initially in the hepatic region, then later on there will be descent of the cecum, okay, to the iliac region, the right iliac region. Okay, all right. Any doubts? Now you can ask me doubts.
No, sir, when you repeated, you answered my question.
All right. Okay. Okay. The next one. So now you can see the stomach, jejunum, ileum, the proximal ileum, the distal ileum, cecum, appendix, the ascending colon, and the transverse colon. Okay, and the two-thirds of the transverse colon develops from the midgut. Okay, forget about the rest of the parts, that is the descending colon and sigmoid colon, which we will see in the next class. Okay, sorry, in the hindgut. Okay, now we are going to see how the mesentery is developed. So this is the adult mesentery. Okay, in the adult part, you will be able to see all these things. Okay, so when you lift the stomach, you will be able to see the greater omentum. Okay, and when you lift the greater omentum, you will be able to see the transverse mesocolon and other structures. All right. So now let's see like how this is developed. You take a cross section at this level. So here you can see the ascending colon, okay, the descending colon. You're taking a cross section here, so you won't be able to see the transverse colon. Okay, so ascending colon, descending colon, and this is the jejunal lobes. Okay, the jejunal lobes. Okay, now initially there will be they are separate, but later on they unite with one another. Okay, so initially you can see that the ascending colon also has got a mesentery, but then they later on they become retroperitoneal structures. Okay, so initially you can see that they are also having they are also intraperitoneal, but later on because of the fusion they become retroperitoneal structures as both the ascending as well as the descending colons. Okay, now if you take another section, okay, if you take a sagittal section, so in this section which we have seen initially, okay, so we are taking a section like this. So this is the stomach, okay, the stomach, and here this is the greater omentum, okay, the greater omentum, and here is the pancreas, okay, the duodenum, okay, this is the transverse mesocolon, okay, this is the transverse colon, okay, and these are the jejunal lobes. Okay, now this we have already seen. Okay, just for the completion sake I'm showing it. So there will be union of the greater omentum as well as the transverse mesocolon. Okay, and this is the lesser sac. Okay, so this will be the lesser sac. Okay, so that's why when you lift the greater omentum you will be able to see the transverse colon and the transverse mesocolon. Okay, so once you lift the greater omentum you will be able to see the transverse mesocolon, okay, as well as this part which is the mesentery. Okay, the mesentery which connects the small intestine to the posterior abdominal wall. All right, okay, so this is regarding the development of the hindgut. Okay, before that I will show you my presentation here. Okay, so here you can see the, as I said before, the primary rotation is taking 90-degree anti-clockwise, okay, and it corresponds with the rotation of the stomach. Okay, then what happens is secondary rotation of 180 degrees. Okay, and here you can see the cranial bud initially increases in length. Okay, there is the formation of the cecal bud. Okay, there is the formation of the cecal bud. The cranial limb goes inside first, followed by the caudal limb. Okay, then the cecal bud is initially in the subhepatic position, then there will be descent of the cecal. Okay, so initially it is in the right hypochondrial position, then slowly it descends into the right iliac position. Okay, and also you note that all this time the vitellointestinal duct is connected. Okay, the vitelline intestinal duct is still connecting it to the yolk sac. Okay, now what happens? Okay, if this vitellointestinal duct doesn't degenerate, okay, vitellointestinal duct doesn't degenerate. Usually it degenerates. Okay, if it doesn't degenerate, what happens? So this is this sometimes there will be a small protrusion, okay, on the anti-mesenteric border. Okay, on the anti-mesenteric border of the limb. So the mesentery will be located here. On the anti-mesenteric border, you will be able to see a small protrusion. So that's called as Meckel's diverticulum, which is nothing but a remnant of the vitellointestinal duct. Okay, a remnant of the vitellointestinal duct. Okay, so the Meckel's diverticulum is nothing but the remnant of vitellointestinal duct. Okay, now that can be connected to posteriorly to the umbilicus. Okay, so that can be connected to the umbilicus by means of a small ligament. Okay, the vitellointestinal duct or Meckel's diverticulum. I think in the gross anatomy they must have taught you about Meckel's diverticulum. Did they? Okay, the vitellointestinal duct. Okay, also it occurs in approximately 2% of the live births. Okay, and sometimes what happens is there can be an accessory GI portion located in the Meckel's diverticulum. Okay, for example, a gastric tissue can be present, a gastric mucosa can be present inside the Meckel's diverticulum. Okay, or sometimes a pancreatic part can be located inside the Meckel's diverticulum. So when an extra other a part which is apart from the gastric, apart from the ileal portion, the mucosa is located in the diverticulum. Okay, it is likely to be inflamed and it can lead on to what is called as Meckel's diverticulitis. Okay, in the gross anatomy part, they must have taught you regarding this. Okay, so the Meckel's diverticulum is nothing but a remnant of the vitellointestinal duct. Okay, sometimes what happens is the vitellointestinal duct, okay, it will be in the form of a cyst. Okay, so that is the both the proximal and the distal part, they get obliterated. Okay, whereas the middle portion, they remain like a cyst. Okay, so that is called as a vitelline cyst. So sometimes you might note that there may be a small swelling in the umbilicus, okay, behind the umbilicus. So that can be because of the vitelline cyst. The last one is a vitelline fistula. So here, this is the difficult one. What happens is fistula, it is connecting between the two epithelium. So here you can see the small intestine and here the ectoderm. So what happens through the umbilicus, the intestinal contents will come out. Okay, so this requires immediate surgery. So this needs to be detected. So there can be some fecal smell which can be found in the umbilicus. And if it is persisting, it needs to be taken up. The child needs to be taken up for the surgery. Okay, to remove this fistula, vitelline fistula. Okay, so these are the three abnormalities with regard to the vitelline ducts. Okay, any doubts? All right. The next one. I said before that the midgut is initially protruding through the umbilicus. Okay. Then what happens is the midgut slowly is taken back inside. Okay. It then goes inside the abdomen. Okay. Because you know that the length of the small intestine is it's quite big. Okay. It's almost, okay. It is quite big and it takes, I mean, it has to be slowly taken up inside the abdomen. What happens if this midgut does not go inside the abdomen? Okay, if it does not go inside the abdomen, it is called gut herniation. Okay, that is herniation of the GI tract. Okay, so now what happens is here you can see two conditions in this. In one of the conditions, you can see there is the gut is herniated. In both of them, the gut is herniated. But in this one, the gut is protected by the amnion. Okay, it is protected by the amnion. Whereas here, the gut is not protected by the amnion. Okay, the umbilical cord is separate and the gut is separate. Okay, so here this condition where there is amnion which covers the gut, the midgut, it's called as omphalocele. Okay, it's called as omphalocele. So here there is a midgut protection, midgut protrusion, and it is covered by amnion. Whereas in gastrochisis, there is the midgut protrusion, okay, but it is not covered by the amnion. Okay, so now which is serious? The gastrochisis is obviously more serious condition because once the child is born, this will be the intestines are exposed to the external environment. Okay, and the infections are more possible. Both are actually dangerous, but this is more lethal compared to that of omphalocele. All right. So this is the difference between omphalocele and gastrocrisis. Both are gut herniation, midgut herniation, but in omphalocele the amnion is covered, whereas in gastrocrisis it's not covered. All right. Also, other malformations with regard to rotation of the midgut. Okay, rotation of the midgut. Now, in this picture, what can you observe? You can observe the stomach, duodenum, jejunum. Okay, they are all located on the right side. Okay, all the small intestines are located on the right side, and all the large intestine is located on the left side. Okay, so the small intestine is located on the left side, and large intestine is located on the small intestine on the right side, and large intestine on the left side. Okay, so when can this occur? So this can occur and there is incomplete rotation of the midgut. Okay, when there is absent or incomplete rotation of the midgut. So what happens? The cranial limb goes directly into the right side, and the caudal limb, it goes directly into the left side. Okay, so this is non-rotation of the gut, midgut. Okay, non-rotation or incomplete rotation of the midgut. Okay, now here what do you see? It looks normal, right? So here the stomach is there, cecum is there in its proper position, jejunum, ileum, everything is there, transverse colon is there, descending colon, sigmoid, everything appears to be normal. But what is abnormal here? Here, this is called as reversed rotation. How do we detect reversed rotation? Look at this position of the duodenum. Okay, the duodenum is usually located posterior to the colon. Okay, so initially you have seen the transverse colon is anterior to the duodenum. But in a case of reversed rotation, okay, that is instead of anti-clockwise, if they rotate clockwise, okay, if the rotation takes 270-degree clockwise direction, so this happens. Okay, so when it rotates clockwise direction, so here you can see the duodenum is located, okay, anterior to the colon. Now what is the danger in this? So sometimes the duodenum might compress, because you know that the duodenum is a retroperitoneal structure, so it will be pulled, the duodenum will be pulled towards the posterior abdominal wall, and when it pulls towards the posterior abdominal wall, it can compress the large intestine. Okay, it can compress the large intestine, thereby leading on to intestinal obstruction. Okay, so this is with regard to abnormalities in the rotation of the gut. Any doubts? Any doubts? Okay, so you might be given pictures and then ask like what type of malrotation it is. So here you can see it is non-rotation, and here look for the duodenal position. If it is anterior, okay, it means that it is a reversed rotation. Okay, so this is yet another defect. Okay, the one which we have already discussed, the Meckel's diverticulum, vitreointestinal fistula. Okay, why this vitreointestinal fistula is dangerous, and this vitelline ligament is it's dangerous? Because sometimes this might be the cause for volvulus. Okay, volvulus. Okay, you know that volvulus is rotation of the intestinal rotation, which can cause intestinal obstruction. Okay, and sometimes it can lead on to intestinal ischemia and stenosis as well. So that's why this needs to be treated. Okay, now let's go to the development of the hindgut. Okay, the development of the hindgut. Okay, I'll just show you the animation first, then later on we will proceed on to the development of the hindgut. It's quite small. So the development of the hindgut. So you know that this is midgut, the yolk sac, which we have finished. Okay, the hindgut. Okay, and this is the allantois. Okay, hopefully you could remember the allantois, which is initially coming from the yolk sac. Okay, a small protrusion. Okay, from the yolk sac, so which is the allantois. Okay, so that's connected towards the hindgut. Now there is a part of mesoderm between them. Okay, between the midgut, sorry, between the hindgut and the allantois. Okay, a part of the mesoderm which is between the allantois and the hindgut. Okay, and this is called as urorectal septum, because the anterior part is the one which develops into the urinary tract, and the posterior part is the one which develops into the rectum and the anal canal, the hindgut structures. Excuse me. All right. Okay, and this is the tail bud, and here you can see a small protrusion. Okay, so this is the cloaca. Okay, the cloaca is nothing but the union of The cloaca is nothing but the union of the hindgut and the allantois. Okay, the union of the hindgut and the allantois. All right. Now here you can see a small protrusion, that is the genital tubercle. That is the genital tubercle, which later on leads to the formation of the penis in males. Okay, and through which the urethra will pass through. That we will see during the development of the genitourinary tract. Okay, so now we will concentrate more on the development of the hindgut. Okay, so here you can see this is the cloacal membrane. Okay, and now this urorectal septum, it keeps on dividing. Okay, it keeps on dividing the allantois, separating the hindgut from the allantois. Okay, separating the hindgut from the allantois. Okay, so this is a cross section showing the mesoderm. Okay, you can concentrate on this one. So what happens? This urorectal septum keeps on dividing. The genital tubercle keeps on increasing in size. Okay, and finally, this urorectal septum comes towards the ectoderm. Okay, so this genital tubercle is the one which forms the penis, the later penis, or the clitoris in case of females. So this one we will see in the development of the reproductive tract. Okay, so forget about this one. The allantois, which forms the urinary bladder and the urethra. So we will see this in the development of the genitourinary tract. Okay, now concentrate on this urorectal septum. This urorectal septum comes towards the ectoderm and it completely separates the allantois, okay, from the hindgut. Okay, so thereby the cloaca is divided into two parts, okay, an anterior part, okay, and a posterior part. Okay, and here you can see now the endoderm is getting connected towards the ectoderm. Okay, and this portion is called as the proctodeia. Okay, it's called as the proctodeia. Okay, so the anterior part, which is called as the urogenital sinus, which develops into the genitourinary tract, which is your next module. Okay, now the posterior part is the one which develops into the hindgut. Okay, the hindgut. Okay, now this part, the urorectal septum, which goes and joins the ectoderm, and that part which separates the urinary system from the the gastrointestinal system, that is the rectum and anal canal. The part of the skin and the mesoderm which separates the urinary tract from the GI tract, the hindgut tract. Okay, that is the rectum and the anal canal. That's called as the perineal body. Okay, that is called as a perineal body. Now, this is a very important structure. You will know the importance of this when you are dealing about in the genitourinary system. Okay, so this urorectal septum, okay, comes and joins with the ectoderm, okay, completely dividing the allantois and the hindgut, okay, thereby forming the perineal body. Okay, and the hindgut, they transformed into rectum, okay, and anal canal. Okay, the rectum and the anal canal. All right. Okay, there is one more here. One more once. And that's it. Okay, now we will see the our presentation. So here, are you there? Yes. Okay. So here you can see the hindgut, okay, the allantois, okay, and here you can see the urorectal septum, okay, and this is the cloaca, okay, cloaca, the cloacal membrane, okay. Now this urorectal septum keeps on dividing. Okay, the genital tubercle. This is the genital tubercle. Okay, and this completely separating it, the urorectal septum finally divides the entire cloacal membrane. It divides the entire cloacal membrane, forming the anterior urogenital membrane and the posterior anal membrane. Okay, the posterior anal membrane. So the entire cloacal membrane is now divided into urogenital membrane and anal membrane by this urorectal septum, okay, which comes outside, and this is the one which forms the perineal body, okay, which is the one which forms the perineal body. Okay, now these are the abnormalities which you can find. We will discuss this, each one of them later. Okay, now what happens if this anal membrane, this cloacal membrane persists? Okay, if this cloacal membrane persists, it leads on to what is called as imperforate anus. Okay, imperforate anus. Okay, that is the cloacal membrane. If it is persisting and the endoderm does not get connected with the ectoderm, okay, it leads on to what is called as imperforate anus. Okay, that is only the anal membrane is present. Okay, suppose the entire lower part of the hindgut, entire lower part of the hindgut is not formed. Okay, you will be able to see the anal puckering. Okay, the puckering of the anus may be present. Okay, but the anus will not be connected towards the rectum. Okay, so this is called as anal atresia. Okay, anal atresia. Okay, now in this condition you see everything is there. Okay, so there is rectum, anal canal, everything, but the anal canal is not opening into the anal puckering. Okay, it is not opening into the anal puckering. It is opening into the perineal body. Okay, it is opening into the perineal body. So this is called as anoperineal fistula. Anoperineal, because it opens into the perineal body. Okay, the anal puckering is located posterior to it. So this is called as anoperineal fistula. Okay, the next one, you can see the rectum, anal canal. The anal puckering is present, but the anal canal is opening into the vagina. This is the female. Okay, so here you can see the urinary bladder, uterus, vagina. So it is opening into the vagina. Okay, so what happens? Recto-vaginal fistula. In males, what happens? Because there is no uterus and vagina. So what happens? Sometimes there may be anal puckering, the rectum and the anal canal, they might be connected to the urethra. Okay, which is called as recto-urethral fistula. Or it can be connected to the urinary bladder, which is rectovesical fistula. Okay, because the other name for urinary bladder is vesicle. Okay, so sometimes pictures may be given and then asked like what type of defect is that. Okay, so you need to know what are the different types of defect. Imperforate anus, okay, where the anal puckering it's coinciding. Okay, the anal canal, the upper anal canal is formed, but the lower anal canal is not formed. Here the anal canal is completely absent, which is anal atresia. Okay, anoperineal fistula, rectovaginal, rectourethral fistula, and rectovesical fistula. Now, this is another condition which must have been already taught to you. Okay, a Hirschsprung disease. Okay, or it is also called as congenital megacolon. Okay, why it is called as congenital megacolon? You know that the large intestine has got its own nerve supply, right? It's got its nerve supply. You know, the myenteric plexus, the outermost layer of the large intestine has got myenteric plexus. Okay, so this myenteric plexus helps in peristalsis. So now what happens if there is absence of these myenteric plexus? If there is absence of this myenteric plexus, that part of the colon fails to have peristalsis. So now what happens? The portion which is distal to it will be enlarged. Sorry, the portion which is proximal to the absence of the neural crest cells, so that part will be enlarged. Okay, so here you can see that the myntric plexus, sorry, here. Okay, so here the myntric plexus will be absent in this portion. Myntric plexus will be absent in this portion. So what happens? Proximal to this, the colon is enlarged. Okay, and you know that this myntric plexus, they develop from the neural crest cells. Okay, they develop from the neural crest cells. So this part don't have the nerve supply, and when they don't have the nerve supply, they will be constricted. So the proximal portion will be enlarged. Okay, the proximal portion will be enlarged, leading to what is called as megacolon. So usually the child will be presenting with constipation followed by diarrhea. Okay, so there will be protruded abdomen. Okay, there will be constipated for 2 to 3 weeks. Then there will be overleaking diarrhea. Why there is overleaking diarrhea? Because when the fecal matter stays in the colon for a long time, the bacteria acts on it, it changes into liquid, and then slowly it might leak down. Okay, so that is constipation altered by diarrhea. Okay, and a protruded abdomen. Okay, suspect congenital megacolon. The treatment is you need to remove the denervated part and anastomose the remaining parts of the colon. Okay, all right. So this is in detail, like whatever I have described just now. So here you can see the urorectal septum. This is the primitive urogenital sinus, the cloacal membrane. The cloacal membrane is divided, okay, into the anterior part and a posterior part. The posterior part is called as the proctodeum. Okay, and here is the perineal body. Okay, this is the urogenital membrane and this is the anal membrane. Okay, this is in detail. I have just described them. Okay, you can have a go through on it later. Okay, now in an adult, in a cross anatomy part, you know that the caudal part, okay, the caudal part of the rectum is developed from the ectoderm. Okay, because the anal puckering, the anal goes inside. Okay, and this is the endoderm. Okay, so the endoderm means the ectoderm. Okay, where does it meet? It meets at the pectinate line. Okay, it meets at the pectinate line. Okay, so that's why the anal canal, if you have seen, okay, the proximal portion of the anal canal is supplied by inferior rectal artery. Inferior rectal artery, which is a branch from the inferior mesenteric artery. Okay, inferior mesenteric artery. Okay, inferior rectal artery. Whereas the part which is, sorry, the here, sorry, this one, sorry, inferior rectal artery supplies the caudal part. The inferior rectal artery supplies the caudal part of the anal canal, whereas here it is supplied by the superior rectal artery, superior and middle rectal arteries. So the superior and middle rectal arteries, they develop from the inferior mesenteric artery, whereas the inferior rectal artery, it comes from the internal iliac branch. Okay, it comes from the internal iliac branch. Okay, and the pectinate line indicates the part where the ectoderm meets the endoderm. Okay, pectinate line. Okay, so this is the place where the transformation can occur between the ectoderm and endoderm. Okay, and why this is important? This is also, you must have read about the hemorrhoids, external hemorrhoids and internal hemorrhoids. External hemorrhoids is when the venous veins are dilated below in the ectodermal region, which is painful. And the internal hemorrhoids or when the veins which are dilated beyond the pectinate line, so which are painless. Okay, internal hemorrhoids can be due to portal hypertension. Okay, internal hemorrhoids can be due to portal hypertension. So all those are gross anatomy. So main thing is you need to know where is this line, the pectinate line, how is it formed, and what is the importance of this pectinate line. Okay, so here some other defects which are given in your Langmans. So here you can see the rectum anal canal is connected towards the urinary bladder. So urethra. So this is the urorectal fistula. Here it is connected towards the vagina. So it's rectovaginal fistula. Okay, here the anal puckering is different from the anal opening. So this is rectoperineal. Okay, and this is imperforate. The anal membrane persists. Okay, failing to break down. Okay, so this is imperforate anus. All right, imperforate anus. Okay, do you have any doubts? Do you have any doubts? Any doubts? Okay. All right. Now one. All right. Okay. I will stop the recording.